Happy Wellness Wednesday, everyone. We are going to be talking about perimenopause today. And let me tell you, this is going to be the most exciting topic for me because I am going through it right now. So anyone listening here that is going through perimenopause or that one who's going through perimenopause, join in because this is a topic you are not going to miss. And for all you women that are going to eventually go into this, you better know about this because it hits you like a truck. Hey, Keith, how are you?
Hey, I'm looking for the truck. So.
You're looking for the truck? You know, this is such an interesting topic of perimenopause because nobody talks about it, Keith. And menopause is like once you've stopped your period completely. Perimenopause is leading up to that. So you have these hormones that are either too high or too low. So what goes up must come down. So you have these fluctuating hormones that one day you're up, the next day you're down. And then you've got these mood swings going on at the same time. And you're getting these night sweats and anxiety. And it can actually occur in your late 30s to your 40s. So a lot of the time, Keith, women will go into their doctors and say, I have this ton of anxiety. I don't know what's going on. It's absolutely excruciating for these women because they don't know what's going on because there is no proper diagnosis. There is no lab test. Not only that, but our metabolism slows down. So you start to gain weight. So we're going to talk about all this fun stuff, guys. Anxiety, weight gain, hormone changes. And this is what perimenopause basically is. Keith, do you want to add to that? Because I know you see a lot of women and you do a lot of hormone support for women as well. I want to get your take on this perimenopause situation.
So I don't want to depress anyone with my first comment, but it can last up to sometimes 10 years, sometimes even longer.
Yes.
And really, perimenopause doesn't have a clear definition. It's the stage between premenopause and menopause. And as you're saying correctly, menopause is a state where you haven't had your period for 12 months straight. The problem in perimenopause, your cycle could be 25 days 1 month, 28 days 1 month. You can miss a month. It could be all over the place. And I think that's the trouble with it. And that's the problem. It's very unpredictable. And I think
you can even have it like every 2 weeks initially. So it's really unpredictable. It's kind of like the middle child, you know, it's like you don't know, you're getting pressure from either side and you kind of have a mixture of both PMS and menopause. So it's a very, it's a very difficult time and it's something that, you can do something about it. So you guys, whoever's listening, stay on because we're going to talk about solutions to this.
And the tough part for people is they think they're getting a break as they get older, but oftentimes the symptoms are worse during perimenopause than during the normal years of cycle. They'll have more breast tenderness. They'll have more heavier bleeding. So it's not necessarily that the hormones are gone. Just the hormones, I would say, are confused.
What's even worse is that nobody's able to really even diagnose this, right? So a woman will come in and say, I'm getting joint pain. I'm having trouble sleeping. My periods are irregular. And they'll be told, or they'll get FSH and LH measured, luteinizing hormone and follicle stimulating hormone. And these hormones only elevate when your body's trying to work harder to produce an egg. But, they change every month. So it may not be high 1 month. So it may be like, okay, well, you're fine. You're not going through anything. So there haven't been any conventional lab tests that really show anything. To suggest, you're going through perimenopause because the anxiety it's extreme. It's quite extreme anxiety. And actually, guys, anyone who has had bad PMS or have had postpartum depression or any of that kind of issue, you're more prone to having anxiety and depression, more hormonal mood fluctuations.
And I think there's also genetics. So if your mother also had similar symptoms, you're more likely to get that as well. Also, the time frame is more common if another family member, especially a parent, has had that as well.
Thank you. Yes, absolutely.
And you made a great point about blood testing. So the problem, we've talked about this before with hormones, blood tests measure inactive forms of hormones. which doesn't really tell you much at the end of the day. And we'll talk more later that there's better measurements and time of month measurements where we look at things like saliva testing, for example.
So Keith, let's just then talk about this. So we were talking about the symptoms of, a woman can have fluctuating symptoms of hot flashes, fatigue, mood swings, periods that are going crazy. You're having them every 2 weeks or missing it, or, it's just everything is it's chaos. You feel like you're actually going insane. And I promise you, you're not. Your hormones are just going insane. It's not you, it's your hormones. So trouble sleeping is a big one. So all of did I miss anything? I'm just naming all the symptoms I've had.
So what's the ones that we add that we haven't talked about before in premenopause are, for example, vaginal dryness starts to begin.
Right.
You start losing lubrication. Bone health starts to be affected. That's the first time where we start to see bone as estrogen starts to deplete, bone health. The next one is actually cholesterol levels rise. That's one of the first times women will see high cholesterol. And if you think of heart disease, heart disease really begins in women when they start losing their hormones, when that risk begins, which is often 10 years later than men, which is a lot of people think around 60 years of age that happens. Also, fatigue, sex drive will go away. Hot flashes and night sweats, of course, will come as well. And urinary symptoms. So because of the vaginal dryness, women are more prone to urinary tract infections, for example, and have to be careful about that as well.
No, those are so important to add in there, especially, a lot of women not really understanding the risk of fractures and bone loss during this time of perimenopause, because this is a really important time to be careful of all of these. So also, I wanted to bring up thyroid issues. 80% of women, that have perimenopausal symptoms have something going on with their thyroid as well.
Yeah, and it's often when the thyroid, if you look at a lot of diagnoses are made, that's often when the diagnosis of an underactive thyroid is made, when those symptoms start to come and really, and I've seen this a lot recently in practice. People have subclinical symptoms where they don't realize that their thyroid is off, and the onset of perimenopause can really trigger that to really become much, much worse and more problematic.
Very true. So if we're not going to do, the blood tests are not the end all and be all. So Keith and I quite often use saliva and urine. Keith, do you want to talk about those tests and explain why they are so great?
So as I was saying before, we talked about blood tests really measuring the inactive form of the hormone, which doesn't really tell you very much at the end of the day if you think about it, right? You want to measure how much activity there is. So, and we talked about in the past how even the NIH looked at a study, National Institute of Health, showing that the best way to measure often is saliva, and we can measure in urine as well. And so we're looking at the active forms of the different kinds of estrogen, progesterone, DHEA, cortisol, again, is important. And you mentioned before FSH, which is follicle stimulating hormone, and LH, which is luteinizing hormone. And testosterone, of course.
And testosterone.
Sorry about
because you're measuring free hormone. And also what we like to measure in addition is cortisol. So cortisol is a huge factor in all of this. It's kind of like, how do you explain cortisol in the mixture of all of this, Keith?
I think cortisol is the person sneaking up behind you to try and kidnap you. And what it is cortisol, and we talked about before, cortisol is often made from progesterone. So progesterone has a decision to make. Do I go make sex hormones or do I make cortisol? And so when you're stressed, the body says, we have no choice, we're going to make cortisol. And that really exacerbates the symptoms of perimenopause. The higher the cortisol level, often the worse the anxiety, the worse the sleep issues, the worse the hot flashes, the night sweats will become.
And that's why I really want to, base some of what we're talking about is supporting the cortisol, because it's kind of like a domino effect, right? So you keep getting the high cortisol levels, and then you keep getting the shutdown of the other hormones. So the key is to really fix those adrenal glands. We talked about adrenal fatigue a couple weeks back, but we're going to just touch on some of the points on adrenal fatigue again to support perimenopause. Okay, so we're going to do the tests. Let's go back to the tests. So we said we're going to do urine, blood, and saliva.
Right. So we're going to measure those different hormone measurements. So remember, we talked about there's 3 forms of estrogen we predominantly see. The first one and the most common one is estradiol. And that's the one that often people will supplement for low hormone levels. And that's the one that has a lot to do with, developing female characteristics. A lot of the cycles having to do with the menstrual cycle come from that. Then the other 2, which is estriol, which is more predominantly seen in pregnancy. And the last one is estrione, which you really don't see very much of until women go through menopause. So you want to make sure that they're in a healthy balance as well. In addition, progesterone, we talked a lot about, very important. And then there's DHEA. The DHEA is kind of funny. It doesn't have a direct role in the body, but it's like kind of the conductor. It determines what each of the other parts are doing. So without adequate DHEA, you're not going to have enough estrogen and you're not going to have enough testosterone. So DHEA is that conductor, looking at that. And again, that's another hormone made by the adrenal glands.
Yes.
And
really
we started
important hormone.
And even your sex hormones, estrogen, progesterone, testosterone, can also be made from the adrenal glands. Even though your ovaries, as a woman ages, may not be making hormones, you have other sources of production. So you have to be aware of that as well, too, for that reason. And then we have FSH and LH.
FSH and LH, yeah.
So FSH, is pretty much there through your whole cycle. It's what helps an egg being released by the body. And LH is actually says, okay, ovulation's coming. So when we get an LH surge, that's our kind of signal that ovulation is here. And of course, the last one, testosterone, which is important in women as well as men, and actually often missed when we measure hormones, right? We're so focused on estrogen and progesterone that testosterone is often left aside, and low testosterone can be such a cause of symptoms in women.
It's horrific. I've experienced it, guys. Trust me, it's horrific. And a lot of the time, patients will come in saying, doc, I have joint pain and I'm having trouble sleeping. That's like a very telltale sign that there is some kind of testosterone deficiency happening. And we can work a lot of that sometimes with DHEA alone, because we don't want to give testosterone right away, because we want to find out why it is that the conversion of testosterone is not happening. Is there something going on in the adrenal glands, for example?
And one of the reasons we do see where estrogen and testosterone can be off is especially in insulin resistance, for example. So pre-diabetics or diabetics often will have an abnormal production of estrogen and testosterone. Also, when we gain weight, fat cells also like to make estrogen, and that can cause even more imbalance as well. But not the estrogen we want, unfortunately.
Not the estrogen we want, the bad estrogen. Okay, so we talked about the different tests that we can do, because your conventional medical doctor will probably just do like an FSH, LH, and hormones if you're lucky. So we recommend, going to your integrative doctor or your naturopathic doctor. We run a lot of these tests. We run saliva, we run urine, and we're able to even see the metabolites of these hormones. Keith, can we talk about some of these metabolites and why they're important?
So each of the metabolites has a factor that plays a different role. So we look at, and again, those are the active forms of the hormone that really have an effect and work. And I want to get back for a second about testing, if you don't mind. So one of the things also, the time of the month when you test is so critical as well. I think that's what people often miss, where you want to really test when those hormone levels are close to their highest level. And I typically do that around day 19 to day 21 in a woman with a 28-day cycle, so that it actually is high enough that you can measure deficiency. Because if you measure in the first half of the month and looking for progesterone, you're not going to really get much information off of that. And that's why it's really critical. And again, so going back to metabolites, so looking at different roles. And again, when it comes to estrogen, not all estrogen is good. And that's one of the problems we look at. And estrogen has different roles in different parts of the body. So we want to make sure that the body's converting to proper metabolites that actually are helping the body work, rather than what we call the metabolites. And some actually, it can even be, leading to cancer, for example, if they're being produced. Or actually, we see from testosterone the same thing. You don't want too much, as a woman, probably and or testosterone. So you don't want much, you want more of that free testosterone to be there.
So we're looking at markers like 2 to 16 hydroxyestrogen. So any of you women that have seen, a naturopathic doctor or an integrative doctor, you'll have seen that these tests that come back that look like they're in completely different language, and you'll see all these metabolites and pathways. That's what's happening. We're looking at those pathways and seeing, okay, how is this person converting? Because we can base then our diagnosis and our treatment on how we're going to put you on either bioidentical hormones, or we're going to put you on botanicals, we're going to put you on adrenal support, we're going to put you on vitamins with methylation. So having said that, Keith, give us some of the markers, the other markers. I know we did the 2 to 16 hydroxyestrogen. What about the, COMT?
So COMT is this new gene that well, it's not a new gene. I guess it's always been there, but it's
always been there.
We
just
but
talking
we've actually
about
kind of looked at. Yeah, I want to actually, before you say that, when I actually look at all those metabolites, I have to have a cheat sheet next to me. It's so complicated. I can never remember it. And I have to always refer back to it. So going back to, we talked a lot about MTHFR, which is one of the more common genetic defects, which affects folic acid. The other one that's really now kind of gaining a lot of traction, and we're looking at more and more, is COMT. And the reason why COMT is such an important gene, it plays a major role in what we call inactivation of neurotransmitters. So when your body, when it's stressed, has all these high levels of dopamine, serotonin, norepinephrine, you don't want those to be there all the time, right? Because if they're there all the time, sleep probably is not happening, for example. Exactly. So COMT helps the body get rid of that. And that's really effective. What's also it does, it actually
it's kind of like a garbage disposal, right? For the dirty hormones.
It's like it's a shovel. It's taking everything and shoveling and saying, here, liver, take this, get rid of this. We don't want this anymore. And because you don't want to always be turned on. I mean, we know that. We talked about how adrenal fatigue, for example, happens because of these chronic high levels of neurotransmitters always being there. Cortisol, another one being in that category. But it also plays a major role in estrogen. So it also does very similar things to estrogen and some of its metabolites. It's able to get rid of the estrogen you don't want. What's also interesting, it actually has a protective effect for women against breast cancer. So having the proper, and what I mean by the proper gene is not having the genetic variant, which is a problem, but having the normal genetic variant is really critical, because it actually serves in protecting against breast cancer by getting rid of some of those estrogen metabolites we talked about that shouldn't be there, and having a protective effect through that. And so, people with this genetic thing are more, I'm sorry to interrupt, more prone to anxiety, to depression, to mood.
That's what I was going to ask you.
Okay. See, we're in sync all the time.
We're in sync.
And also, we've talked about this before. I almost call it, like you said before, the detox gene. So there are some thoughts that people who cannot detoxify, get rid of, molecules and toxins, that environmental as well, may have this kind of genetic defect.
Yeah. So you can have like a double positive and then a positive negative, like a heterozygous gene and a double positive gene. Is there a difference, Keith, between the two and how you would prescribe?
Yes. And so definitely, because the people with the double positive gene really are going to be much more symptomatic. And we talked before about hormone replacement, for example. Those people with that double gene, I would be much more worried about actually giving about that, because their risk becomes greater. And because and I didn't explain it before, but it's the way the gene handles estradiol and causing something called 2-methoxyestradiol to be there, which inhibits the growth of cancer cells. So people who have that genetic variant, especially the homozygous, which means copies from both parents, are more problematic and more at risk for that case. Right.
There was that study done in 2002, the Women's Health Initiative. I don't know if you remember that study, and they looked at women over the age of 60, and they gave them progestin and synthetic progestin and estrogen, and then every woman and their dog came off of estrogen because everybody got so scared.
And remember, people don't remember, you know what that estrogen came from? I mean, if you hear where it came from, it's actually from horse urine.
Yeah.
So the original, so I probably will not go to the pharmacy and get medications made from horse urine. That's me. But
Let's
but
not
again,
do that.
but again, what
Well,
happened is I think
Hold on, Keith. The symptoms of perimenopause and menopause are so bad that you will do anything. Like people
right.
could care less. But
Well, we can do more
hilarious enough.
natural, but no more natural
Yes.
forms. I take that back. You are correct. So, but again, a lot of times in the initial, and I think what people got really scared of is the risk of cancer. And I
Yes.
think one of the reasons for that is we violated what I call physiological laws. So what we did is we gave doses of medications in different than the body's natural way of handling
Yes.
it. And different times, like we don't have estrogen every day. We don't have progesterone every day. So, but people were taking medications, example, progesterone, every day of the week. So,
Yeah.
and for a whole 28 days.
They weren't taking progesterone, they were taking progestin. So
Right.
they were taking the synthetic progesterone, and they were taking the synthetic, as you said, estrogen, estradiol in a horse urine format. Wasn't even, so, that, and also they were doing it in women over the age of 60, which is a bit old. I mean, that's not old, but it's old for like, people should be doing this, they should have done the study on a younger group of people. In any case.
And if you actually look at the original estrogen usage, it was actually for preventing fractures. So really that was the key. So estrogen and heart disease. So if we go back in time, but what they actually showed that the benefit really goes away after 5 or 10 years post-menopause onset. So again, so you're starting it at such a late time, you're really losing some of that benefit that you would have had otherwise.
Absolutely. Great point. So here we are with using synthetic hormones, and people are like, should I use it? Should I not use it? Should I suffer through this? And the thing is, Keith, you shouldn't have to suffer through menopause and perimenopause. There are amazing solutions and treatments and practitioners like Keith and myself that can help you get through it. It's, it's something that is going to happen to all of us women. Some women are luckier than others, but for some of you that get it, it hits you like a truck. So, can we talk about, so we talked about the COMT, we talked about the different metabolisms of the hormones. Can we go into like what people can do about this? What are we advocating people to do?
So, I mean, the two key things you started bringing up again is, we call botanicals or your natural supplements first, or what we call a second choice, which is bioidentical hormone replacement.
Right.
So those are pretty much the two things. I mean, the other things like proper diet, lifestyle, all critical in almost anything we talk about. Those are really critical as well. And also when you think about that, and I forgot to bring this up before, is when we think of symptoms like someone who's having hot flashes all day, that's often related to estrogen, depletion. And someone who's having, deficiency. And someone who's having night sweats often is progesterone deficiency or trouble sleeping. Right. So you want to really think about where that deficit is and where that problem is. So when you make a choice on how you want to treat.
And what I quite often do with patients is I test them every 3 to 6 months. A lot of the time practitioners will just put them on a program and say, okay, bye, go away. But our hormones change. We're very complicated, us women, in terms of the way our hormones react. Now, I didn't mean that as we're complicated as a species, but we're complicated in terms of hormones. We have more hormones than men, and they fluctuate on a daily basis, and it depends on that cortisol again. Like what your cortisol is doing is how your hormones are going to react. Now, when you said diet, lifestyle, exercise, all of those things, there are women that come to me, Keith, and say, I'm exercising really well, I'm eating really well, but I cannot get the fat off the middle belly. And it does take more work, ladies, at our age, when you're perimenopausal, to lose that belly. So you have to be really more careful about what you're eating than when you used to be in PMS, for example. Your exercise has got to be, really regular, because it does help with hormone metabolism, and your lifestyle, your stresses. You have to really work out in terms of how you're dealing with your stress, and take adrenal support, because this is going to be your savior, ladies, because that's like, this is your foundation. But it's a little bit more hard work than it was when you were in your 30s, unfortunately.
This aging thing that we go through, huh?
But when you do it, Keith, the results are amazing, because I'm going through it. And, you know, and even me being a naturopathic doctor and knowing and treating all these women, I was just like, what is happening to me? Am I going crazy? Like, what is going on? And then
it's like, when's the alien gonna leave my body?
Right? Like, who is that? And where did she come from? And once you treat it, you feel so much better. I mean, there'll be times like I'll talk to you on the phone and I'm like, oh, I'm dragging my feet, Keith, and it's because of my fluctuation hormones. And then some days you'll talk to me and you're like, God, you sound really good. Like you know, and that's because, you know, I've worked out what I need to do to support my hormone balance. Because if you don't support that balance, and if you don't start at the foundation of diet, lifestyle, and exercise, you're going to go down a path that's, you know, really, 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 it's very stressful. And there aren't any resources. There isn't a magic bullet pill that you can take. So having said that, let's tell everybody what they can do, because you can take a hold of this monster. It is like a monster, or an alien, rather.
So typically people start with, we call the botanicals, or some of the national supplements. One of the most common ones is wild yam. So people oftentimes, especially if they're having night sweats, will look at, you know, using wild yam, because it helps stabilize estrogen activity, but it also helps produce progesterone. So that is often used, and it kind of functions as a low dose progesterone. So a lot of people use that typically with night sweats, for example, or insomnia, where they can't fall asleep at night, and even sometimes to manage cortisol to some degree as well. That's a big. The next one we talked about last time, black cohosh. So it's used, and that's a lot with mood, sleep disturbance. It's a big one as well. Also hot flashes and night sweats, right? So again, you're trying, in a sense, in a low dose, replace some of that estrogen that's missing. And before I go further, I forgot to mention that the other thing is, that's when estrogen dominance plays even a bigger role, right? When your hormones are leaving and you're already prone to higher estrogen, you're going to feel more of those symptoms of estrogen dominance, because the progesterone will even be lower than that estrogen. That decline would be much faster, actually. So the other one, which is we talk about all the time, vitamin D.
Vitamin D.
And I learned something which I didn't know, so that vitamin D deficiency leads to prolonged and heavier bleeding.
Yes.
So I never knew that. So that was something I learned. You have to tell me these things. And it's also helping with, you know, balancing out hormones as well. Ginseng is another one, which for hot flashes, night sweats. Quai we've talked about before, to balance estrogen levels. And I can never talk without adding in magnesium, you know, our anti-stress supplement.
Yeah.
And again, you said so critically, if cortisol is lower, you're more easily and more likely to balance your other hormones. Progesterone's going to say, hey, now I can be a sex hormone. I don't have to be an adrenal. And that's really critical as well.
Brilliant, brilliant. You know, also, Keith, you know, people in Germany have been using things like black cohosh, you know, for decades. You know, we were talking about this last time. There was a product on the market that was trademarked called Remifemin, that a lot of, I still think it's on the market, and that was their major treatment for perimenopause and menopause. So very cool that, you know, we've known about all these forever and ever and ever, but nobody talks about it. So we're talking about it, guys. So, and then magnesium, you said, all right. And then bioidentical hormones you talked about. People are like, okay, if I've had breast cancer before and I'm really suffering and going through a really bad phase, it's an interesting, you know, everyone is different. So we can't, you know, we're not your doctor, so we can't tell you, yes, go on bioidenticals, or yes, go on botanicals. You have to talk to your provider for your individual.
And also
case.
breast cancer, there's different types. There's some that are, we call estrogen
Yes.
and progesterone receptor positive. So that's really important to know first. So bioidenticals are the interesting thing. There's so many different delivery methods. There's from injections to gels to creams to patches to pills. Actually, I'm seeing more and more patch use. More and more, I'm seeing more women using estrogen patches than ever before to make ease of absorption and, you know, not having to remember as well, you know, every day to take something.
Because that's the other thing, guys, your memory goes as well. You can't remember things. And also, what about the sublingual suspended in oil?
Sublingual as well, too, yeah. Again, you know, remember, because it's a fat soluble, we talked about before, that it has to be in an oil base to be able to take it. So that's why sublingual works as well, too.
Especially
you know,
if you have pets. If you have like animals or, you know, I have a dog, so I always worry about, you know, if I'm putting my estrogen on my, you know, he's going to come in and cuddle with me and he's going to end up getting a lot of estrogen. And so I've started the sublingual and I'm just checking it out to see how it goes. So again, you ladies, you're going to try your own. Your practitioner is going to work with you to get what's right with your body, because we all take things in differently. I mean, Keith, if you and I were to take the same drug right now, say you and I decided to take, I don't know, say mushrooms, for example, that would be quite funny. And we took that and we took it at the same time, we would detoxify that drug 1,000-fold differently. Can you believe that?
Yes.
Like that is just
and that's
insane.
why it's challenging, and I think that's what. And I think you made it so great point about before. That's why measuring them on every 3 to 6 month basis. I've learned, and this is what I've seen in practice, that sometimes I supplement estrogen and progesterone, and I'll see someone's testosterone level go way up.
Yes.
So you don't always know how someone's going to be utilizing that hormone, and that's why it's so. And then we were able to correct it and adjust for that because of that. And so the person ended up having not much estrogen available, even though we're taking estrogen, because testosterone went so high. And then we can adjust it so that then it's actually working on both. And that's really critical.
And so we can look at bioidentical hormones, ladies. If you have had a history of breast cancer, any kind of cancer, you know, that's something definitely to talk to your provider about. But I would definitely at least get on the diet, lifestyle, and supplement bandwagon of like vitamin D, vitamin E, especially if you're having, you know, vaginal dryness. Vitamin E is super, super important with hot flashes, and vitamin D. Make sure that you're on those two things at least, and then talk to your provider about what it is that you might need in addition.
Actually, I forgot one other method. It's also vaginal suppositories also. That's and sometimes in some of my patients, with their gynecologists may use in cancer patients, a very, very low dose to help with vaginal dryness and lubrication that's only active in that area.
Good one. That's a good one. Even vitamin E suppositories, you know, you can start with, are supportive. But yes, the suppository, hormonal suppository in low doses are safer and effective. But again, speak to your doctor. Okay.
And I've had a lot of women very successful with vitamin E to help with vaginal dryness by using those suppositories. Been very, very helpful, actually.
Me too. Yeah, a lot of patients have noticed. Even women in perimenopause, you know, they go through a much easier time when you give them the vitamin E suppositories. Okay, so there are different times of the month that you take the supplements, like day 1 to 14. So make sure that you're speaking to your doctor about this. Also, you remember that you want to check your hormones on day 19 to 21. Those are really important. Even, you know, blood and urine and saliva, those are really important times to check. Also check your cortisol, your DHEA, because those are going to tell us the foundation. Keith, anything else we wanted to add? Oh, check your vitamin D levels too, to see how they're working.
And the other thing about that is if you do it on day 20, the first time, you want to try and be consistent so you can really interpret the difference. So you don't want to go to day 5 because those may not be really, you know, you cannot really compare those properly. And it's really important to do that on a regular basis.
Amazing. So you guys remember, the only thing constant is change. And in us women, our hormones are changing all the time. We go from PMS to perimenopause to menopause. I mean, it's we're constantly changing. So this is why it's important to change up your routine and really start on a routine so that you know exactly. There's one last thing, and this is something I also need to work on. So everyone, let's support each other on this. Exercise, because the more muscle mass you build, the more supportive you get with things like growth hormone, which then help your whole overall hormone activity, and it's anti-aging as well. So we're going to answer a few questions before we go.
This
Keith,
one's
do you
really
want to
great.
answer this?
Yeah, so if you don't, I'm going to read it first. What if you don't cycle 28 days? When do you test? So I test about 3/4 of the way through your cycle. So whatever that is, it would be the third week, or if it's 21 days, it could be day 15 or 16, but it's about 75% the way through.
Yeah, so just assess where you are 3 weeks into your cycle. Just make an assessment from when your last menstrual period was. Is that what you're saying, Keith?
Correct. So what I would do is, if you're running, if you're not on the 28-day cycle, thank you for clarifying. And so you're on the 25-day cycle. So you may want to do 75% from day 1.
Gotcha.
To multiply. So about day 17, day 18.
17, 18.
Instead of 19, 21, and then adjust based on that.
Brilliant. That makes
great question, by the way. Excellent question.
Yeah, thank you guys are asking amazing questions. Any other questions before we go? We'll give you a bit of time to ask any questions. Keith, next week we're going to talk about menopause and postmenopause and what that actually means, and what to do during that time, because the PMS cycle and the perimenopausal cycle are so interlinked. The postmenopausal and the menopause are quite definitive. And, there is a lot you can do during that time. The perimenopause time is again, it's, you can start getting it in your late 30s all the way up until your, late 40s. It is so incredible what happens to your body. But guys, you can do something about this. And I'm so excited you're taking all the supplements and vitamins, following the plan in my book. It's super important. Keith, Dr. Keith, do you do online consultations?
Through telehealth, correct, yes.
Okay, so what is your website, Keith?
www.centerforbalanced with the D at the end, health.com.
Okay. I haven't had my period after stopping breastfeeding. It's been 2 months. This is from Shauna. Anything I can do?
Should I answer? So when you're breastfeeding, it can take about up to 6 months after stopping for your hormones to return to normal levels. It can take a fair amount of time. There's a lot of suppression of hormone levels during the breastfeeding period.
I would also make sure you check your iron levels, because sometimes iron levels can be low and that can delay you getting your period. But it is totally normal to, not get your period right away. Enjoy those moments, Shauna. All right, everybody here. It was so great chatting to you about perimenopause, which is something very dear to me because I'm going through it, but I am fighting it with everything in a good way. Fighting it meaning I'm taking, the bull by the horns, and I'm following diet, lifestyle, supplements, and I feel so much better. And it really does make a difference when you actually do those things, because you can actually see a massive difference when you're eating right. So that's kind of the light at the end of the tunnel for everybody listening. All right. Happy Wellness Wednesday, everyone. And we look forward to seeing you guys next Wednesday to talk about menopause and post-menopause. We love you guys. Bye.
Have a great day. Bye.
Bye.